Hello. Good evening, sir.
Good evening.
Yes, sir. We'll be starting in 10 minutes, if that's fine.
Sure, you can go ahead.
Okay. Thank you.
Hi, sir. Good evening.
Can we start?
So we'll start in 5 minutes.
Oh, okay, no problem.
Good evening, everyone. We'll be starting now. It is my pleasure to welcome everyone today for the pre-conference of Annual Undergraduate International Academic Conference Spasht 2022. I would like to welcome all of our eminent speakers from different walks of life who have come here to share their knowledge and experience to this vast student community. I would like to introduce the speakers of the panel now. First, we have Dr. Raghunatha Rao, Senior Clinical Advisor and Senior Consultant, Medical Oncologist, Founding Director, Homi Baba Cancer Hospital, Visakhapatnam. I welcome you, sir.
Thank you very much.
Then we have Dr. Suresh H. Advani, Chief of Medical Oncology in Shushruta Hospital, Jaslok Hospital, Nanavati Hospital, SL Raheja Hospital, HN Reliance Hospital. I welcome you, sir. Dr. M. Vijay Kumar, President of Indian Association of Surgical Oncology, Vice Chancellor, Yenapoya University, Mangalore. I welcome you, sir. Then we have Dr. K. Pavitran, Clinical Professor and Head of Department of Medical Oncology, Amrita Hospital, Kochi. I welcome you, sir. Now I would like to welcome all of our participants. We hope that this session is informative and you will get an insight in the leading trends in oncology. I would like to invite Dr. Raghunatha sir to start off the session.
Good afternoon, everyone. It's an honor to be able to talk to undergraduate students. I purposefully avoided a PowerPoint presentation so that I can talk verbatim. First and foremost, I would like to introduce to you what is so unique about cancer or its systematic study, which we call as oncology. As most of you understand, it is purely the study of tumors. I will in general talk to you about oncology and specifically about medical oncology. The subject I have been practicing for the past 3 decades. So what is very unique about cancer is that cancer needs, in most instances, a genetic change in the cell. Very rarely an epigenetic change can also drive it. And this genetic mutation actually causes 2 very specific changes in the cell. One, it makes the cell immortal. So it is as if the cell can perpetually divide into any number of cells, any number of times. The second very important is that it can prey upon the host through local invasion or systemic metastasis. Both these are equally important in cancer. So one, we know that the cell is driven to be perpetually dividing, or what we call as immortalization. And the second, that it can destroy the host through local invasion or through systemic spread throughout the body. Well, if that is so characteristic of cancer, what is the purpose of cancer? Or what is the purpose of, is there anything beyond science to understand cancer? Most cancers seem to be able to thrive in a highly anoxic condition. So it is as if nature were experimenting with life itself, which can actually, hopefully, in the near future, when man is stupid enough to forget that he needs an atmosphere, he needs oxygen to survive. So it is perhaps experimenting to see if life can survive in anoxic atmosphere. I'm not sure, but this is what my professor, the late Dr. Krishnamurthy, the founder of the Cancer Institute in Madras, used to tell us. Cancer, of course, can occur in plants. It can occur in many multicellular organisms. But do we see it routinely in every single animal? For some peculiar reason, cancers seem to be absent in those who have a notochord or those that have a cartilaginous skeleton as opposed to an osseous skeleton. For example, you don't find cancers in mollusks, you don't find cancers in sharks, you do find cancers in fish. So once the notochord is lost and you get a true spinal cord, you seem to be able to be prone to develop a cancer. Do all mammals develop cancers? Yes, every single mammal can develop cancer. Do all plants also develop cancers? Yes, most trees seem to develop cancer, although the tumors are rather non-metastatic. Since there is no lymphovascular system or circulatory system as it is, there's only a xylem and a phloem in a plant. So most cancers in plants are actually localized as calluses. So yes, there are cancers in plants. There are cancers which can occur in animals. For some peculiar reason, the marine life seems to be bereft of cancers. What about the insecta? What about the annelida? No, they don't seem to be prone for cancers. So, having known what is the basic definition of cancer, let us see how its study is very exciting. This is the only branch of medicine where there is nothing called a treatment based upon a presumptive diagnosis. That means there is nothing like a postcard diagnosis and a postcard treatment. Like, for example, do you have fever? Can it be malaria? It can be malaria. Take chloroquine. That used to be a slogan when some of us at least used to use postcards. Nowadays, of course, you don't use postcards, you use an SMS message or a digital platform to communicate, write a mail, but still, there is nothing called a presumptive diagnosis of cancer. So, without any doubt, even if you have a clinical diagnosis of cancer, you have an imaging diagnosis of cancer, or you have a biochemical indication that it could be a cancer from a rise in a tumor marker, like a beta-HCG in a germ cell tumor, an alpha-fetoprotein in a liver tumor, or some such marker like CEA in a GI tumor, or a CA19-9 or a CA125 in a pancreatic or an ovarian cancer, respectively. You still need what we call a histological or a cytological diagnosis. That means we need a pathological confirmation of the diagnosis before we actually broach about this subject to the relatives or to the patient or to discuss it any further or even to stage it. So our first attempt will be to see that we first confirm the diagnosis of cancer, and then, of course, we will go through its management. So what basically are the requirements, or if I should say, what basically should be your attitude or inclination at your level to be able to take oncology as a subject? Well, of course, you can choose it in your post-graduation if you are planning to take radiation oncology as a subject. it is only in India that you can be a radiation oncologist soon after MBBS. Nowhere else in the world is it permitted, since radiation oncologists everywhere else in the world are a subspecialist. That means they first finish being trained as a physician or a pediatrician, and then only they do radiation oncology. There is no direct radiation oncology degree anywhere in the world, except perhaps in India. We don't know the reason why there is an MD radiation oncology and why it is absent in the rest of the world. But anyway, you need to be first and foremost a good physician or a good clinician to be able to take medical oncology. What could be the eligibility criteria? Well, you can do an MD or a DNB medicine in places where there is no pediatric oncology. You could also do an MD pediatric oncology as well, and then or a DNB pediatric oncology, and then get into medical oncology. To be a surgical oncologist, of course, you need to be an MS general surgery. Of course, you could do in the past, at least in certain centers, you could do MD or an MS in obstetrics and gynecology, MS ENT, MS plastic surgery, and in a few instances, in the recent trends for surgical oncology, Dr. Vijay Kumar is there. He will also discuss. ENT can take the path of head and neck. Orthopedics can take the path of musculoskeletal. Urologists can take the genitourinary. The gynecologist can take that. And the thoracic surgery, MS, cardiovascular and thoracic surgeons can take thoracic surgery as a subspecialty. So, but by and large, if you have a background of a surgical oncology, if you wish to specialize into these branches instead of directly entering into them. So what characterizes the study in oncology? We need to learn a little bit about, or in detail, I would say, not a little bit, about the epidemiology of cancer. The epidemiology of cancer is pretty interesting. For example, in a simple country like India, there are wide regional variations in the occurrence of the top 5 cancers across the northern states, the northwestern states, central India, the eastern states, or the northeastern states, or the southern states, and the rest of the world as well. So the Western population see certain cancers quite differently from the way we see it. And of course, within India, we have a wide variation in whether the data is from the rural India, it is from the semi-urban India, or it is from metropolitan or urban conglomerations. So there is a wide variation in the occurrence of several cancers. Not that they are not seen anywhere else in the world, but for example, gallbladder or cholangiocarcinoma is pretty common in northern India, especially towards the Gangetic belt, all the way down into Bengal. But it is quite not so common in western, southern states of India. As opposed to that, we know that the 4 southern states also report quite a high incidence of, you can say, stomach cancer, as similar to what can be seen in the northeastern states as well. So there is a higher incidence of stomach cancer. Stomach cancers, of course, occur with equal felicity across the country. For example, breast cancer in most metropolitan cities is the same. By and large, cervical cancer, of course, is the largest rural women's cancer and the commonest killer of women in India, as opposed to urban breast cancer in Indian women. Most of us are, of course, prone to, through the epidemiological studies, we know that the large part of our cancers are upper aerodigestive tract in nature, so they're caused by tobacco or tobacco products. If you combine alcohol to tobacco, of course, the risk suddenly increases. So we study first with the epidemiology, the risk factors associated with cancer. They share the same risk factors along with other lifestyle disorders like hypertension, diabetes, obesity. And we know that alcohol and tobacco smoking. So they're same for, say, the other lifestyle disorders as well. In addition, of course, we learn specific etiologies of cancer. What is environmental carcinogenesis, or that which can be caused by, say, for example, the ultraviolet light, or for example, the background gamma radiation. What's the incidence because of that? What happens when the background gamma radiation increases, like in Hiroshima or Nagasaki or in Chernobyl? What cancers increase in children, and if they survive, what cancers do they get? What cancers occur in adults if they are exposed to a nuclear or to radiation from a nuclear explosion? We can study. We also study viral carcinogenesis, a few bacteria which can cause cancers, a wide variety of chemicals from the environment which can cause cancer. And of course, we study how to prevent cancer as well. So we learn how to calculate incidence, how to calculate prevalence, and how, of course, to undertake epidemiological studies, even when we do not know what exactly is the risk factor. So epidemiological studies can actually point out to a risk factor or risk factors in a given population. That is how the scrotal cancer of chimney sweeps was discovered. That is how the causation of lung cancer through tobacco was discovered. Even before we knew a single carcinogen in tobacco, we knew tobacco can cause cancer. So it can point out the risk factors which could be associated, and it is left to you for you to see what could be the specific risk factors in a given society, in a given population, in a given geographical area, or, for example, could it have been a hereditary syndrome which causes cancer proneness? We know a few hereditary syndromes, and some familial cancers can run in the families. So all these can be studied under the etiopathogenesis of cancer. Then, of course, we study the systemic disorders, that is systemic systems review in oncology. So most of it, if you can understand, is actually multidisciplinary. Like many other subjects in medicine, as you study deeper, they become multidisciplinary. But in addition to just a surgeon and a physician, for example, a nephrologist and a urologist, a cardiologist and a cardiothoracic surgeon collaborating to a given system of medicine, we have more than one or more than two, in fact, systems of contributing to the study of cancer. So we start with the pillars of oncology. The pillars of oncology truly and indeed are actually pathology, and of course, imaging sciences. So they are the pillars of oncological sciences. One establishes the diagnosis. Two, the second one actually helps you stage the cancer without being very invasive. So imaging is an integral part of oncology. So you need to learn imaging in all its aspects. And then you should learn how to classify tumors, how to use this classification and link it to what we call prognostication or risk stratification in a given individual, taking their race, their gender, their age, their comorbid conditions, and of course, an etiopathogenesis, which could lead to the cancer. So all factors can be studied. And then, of course, the chief modalities of treatment for oncology can also be studied. For example, we study medical oncology, we study surgical oncology, then we study radiation oncology in all their aspects in very detailed, grand detail. And then we study teratronics, or what we call using radioisotopes for treatment of cancer. So we need to understand that nuclear medicine and interventional radiology also have a role in the treatment of cancer. Finally, we learn how to prevent cancer, how to rehabilitate a patient with cancer, and we also learn how to palliate when there is no cancer-directed treatment which is useful for cancer. Most importantly, we learn a lot about what are the steps through which a drug or a device passes before it can be approved or a procedure can be approved as clinically useful in cancer. So we start with basic sciences. So we study how a drug or a device can be, or a material or a procedure can be used in the animals, in the petri dish. Take it through a very systematic clinical research through phase 1, 2, 3, and finally, after its approval, into a post-marketing survival or phase 4 clinical trials. So you could study drug discovery in all its aspects, which is very fascinating, either through an in silico process or through a completely serendipitous process through natural product selection. I told you that we do need to study about the genetic basis of cancer. I mean, not the inherited, simply the inherited basis, but every single cancer seems to be driven, at least initially, by some genetic change which is pro-carcinogenic. So there are certain promoters for this carcinogenesis to occur. There are some initiators to occur to actually start this process. So all carcinogens typically are teratogens. So they cause a change in the developing fetus. So all teratogens are, of course, carcinogens. But the reverse may not be true. All carcinogens need not be teratogens, and all teratogens need not be carcinogens. So it is important to understand we can study in great detail what is the basis for cancer and where we can actually intervene in the etiopathogenesis of cancer. So this study has actually led us to developments in cellular and molecular biology, which underlie the modern practice of medical oncology. So although we do use chemotherapy drugs, we use anti-hormones to treat cancer, but the major change which has occurred in oncology is actually what we call a precision medicine. I don't think it is totally personalized at the moment, but yes, you can personalize in a given way, in a given patient, in a given instance, what is the best choice of drugs and best choice of treatment, whether it's surgery, radiation, or chemotherapy, or combined. So typically use a tumor board, or some people don't like to call it a tumor board. They would like to call it a DMG, disease management group, which can actually help you come to a conclusion of how best you can use this treatment. Well, you can divide the study further into pediatric oncology, adult oncology, hemato-oncology, or geriatric oncology, if you wish. Yes, all these branches are up and coming. More and more cancers are going to be seen as we start aging. And we need specialized methods of risk assessment for patients depending upon their age. Or you can choose by the organ or the system which is affected. For example, hemato-oncology, or you can choose to be somebody who is interested in head and neck oncology, like lung or cardiothoracic oncology, or you can study GI oncology, you can study hepatobiliary oncology, you can study genitourinary cancers, you can also study gynecological cancers. And of course, if you are very, very keen, you can study a single organ like the breast oncology as well. So there are many methods of doing it, and you can actually be an expert in prevention and palliation of cancer as well. So you can go into preventive oncology or into palliative care in oncology. So there are many ways to actually approach oncology. But if you want to be a good medical oncologist or a pediatrics, the basis, the foundation should be as a physician or as a pediatrician, because pharmacotherapeutics and the management of the common conditions are basically the same for the patient of cancer. So many patients of cancer have diabetes, they have heart disease, they have renal failure, they have COPD, they have stroke, they have dyslipidemias. They also get infections which are induced by your treatment, typically very fatal infections. You also cause a large amount of organ damage, how to prevent it, how to actually treat it, how to actually take care of the emergencies which can occur from the treatment or from the cancer. Everything is part and parcel of simple pharmacotherapeutics, which you learn in your general medicine as a postgraduate. So if you can master this, then you can master medical oncology. Well, you can actually go a little further and enter into such very exciting fields like precision or molecular oncology, where you can study what we call approaches like the single gene mutations which can be suppressed. For example, in chronic myeloid leukemia, you can switch off the gene BCR-ABL from getting expressed. And nowadays, we are talking about a remission which is treatment-free. So you can stop the drug. We never thought we could stop the drug in chronic myeloid leukemia, but you are now able to formulate guidelines to stopping the drug and observing the patient. So any number of exciting compounds, the largest number of drugs ever discovered in this world are now per year on a aggregate. The largest are in medical oncology. So the largest number of drugs are targeted towards oncology. Similar research, of course, with similar drugs can be used in ophthalmology, from dermatology, from rheumatology, in nephrology, and several other areas as well. For example, rituximab can be used in nephrology, it can be used in ophthalmology, it can be used in rheumatology, and it can be used in dermatology as well. So there are many compounds which are used in oncology. Even the chemotherapy drugs like methotrexate for cyclophosphamide can also be used in many other areas of clinical medicine as well. So it is all in said, it is one of the most exciting times to be in an oncologist. The American Association of Internal Medicine has actually determined that the fastest growing and fastest changing branch, where probably you need to be up and about your CME credits once every year, not once every alternate years, is oncology, and that too medical oncology. And the most integrative of sciences is also oncology, since it involves many other specialties which have a bearing on the treatment of cancer, starting from imaging sciences to pathology to nuclear medicine to surgical, medical, and radiation oncology as well. So I will stop here since I've been allotted half an hour and it's already 5:02. And if you have any pressing questions, I'll be very happy to take them.
Thank you so much, sir. If anybody has any questions, could you please leave them in the chat box and we'll be getting to it. We'll have a discussion at the end. Now I'd like to invite Dr. Pavitran K for the next talk. Thank you so much, sir.
When you allow me to share the screen.
Yes, sir.
Screen sharing, screen sharing.
Yes, sir, it's on.
Not yet. Disabled. No, still it is not on.
Yes, sir. Could you give us 2 minutes, sir? We're just
Oh,
working.
okay.
Thank you. Sir, it should be.
Yes, yes. Now it is now. Yeah.
Okay, thank you.
Hope it is Hope the slides are moving. Can you hear me? Hello?
Yes, sir.
Slides are moving?
Yes, sir. Yes, sir.
Okay, okay, fine. Thank you.
Thank you.
So what I'm going to cover is regarding cancer immunotherapy. This is Jimmy Carter, who was diagnosed with melanoma stage 4 in 2015, and he had radiation to the brain, then immunotherapy with pembrolizumab. 1 minute. Dr. Advani sir is online. Hello, sir. Okay, sir. Okay, sir. Then you can start. Take up. Okay. Thank you. You can invite Dr. Advani sir. Amrita. Amrita?
Yes, sir.
Yeah, Dr. Advani sir is online. You can invite him.
Yes, sir. Sir has not joined the session yet.
He told he is joining.
Yes, sir. We'll just wait for him to
Yeah,
join.
okay, okay. Questions, I think, otherwise they have to wait. Because they are all busy people. No, meanwhile, you can ask questions to Jagadana Rao. By the time he is joining, that you can do now. Yeah.
We'll now be taking questions for Dr. Raghunath Rao. So if anybody has questions, please send it on the chat box.
You can actually post them online if you want, or in the chat box.
Sir, there's a question. Is the precision and molecular oncology the new approach to treatment of cancer?
The terms are actually not the same. One of them is with respect to the basis for the disease. So is there a molecular basis for the disease? Yes, most diseases will have a molecular basis. Do we have something to treat it with? That becomes precision. Individualizing a treatment would be called personalizing or personalized treatment of cancer.
Sir, there is another question in the chat box.
Yeah.
Do we have an exact reason as such why all mammals get cancer and not the invertebrates? Dr. Advani is on the line, so maybe he will start his lecture.
Sorry, Raghu.
No problem, sir. Please carry on.
I'm so sorry. Yeah. Good evening, colleagues. I'm so happy to be here and interacting with all of you young people. And Raghu and myself, we have worked together a long time. And I know how much I learned from him. And I'm sure he must have given you the feast of knowledge and information. What I'm going to do today in another 10-12 minutes is to give you insight into a disease which was different about 40 years ago and which is different today. And that's what I'll tell you, that probably the disease which we saw 40 years ago, you will never be able to see that, such type of the disease. So one of the such diseases, chronic myeloid leukemia. Put the slides. I'll share my screen with you. So that's a disease, chronic myeloid leukemia. We used to see a large number of chronic myeloid leukemia in 60s, 70s, 80s. All of them used to come with the accidental discovery of high blood count and will have the diagnosis of chronic myeloid leukemia. And initially, we were all happy, very good. We are diagnosed chronic myeloid leukemia, that he will respond well, his blood count will come down. But surely, all these people, next slide, all these people were having a problem. Now, this disease happens because of the balanced translocation between the chromosome number 9 and 22. So when the ABL gene and BCR gene, which is situated on number 9 and 22, when the translocation occurs, there's a new gene, which is a partly ABL, partly BCR. So we call it fused ABR BCR gene, which is situated on number 22. And it is this gene which creates a problem. What does it do? Very simple. This gene produces the protein, a tyrosine kinase, on the cell surface. And not only it produces the tyrosine kinase, but it is phosphorylated, very active, actively phosphorylated ABL BCR gene. And this gene then activates a lot of growth factors in the surrounding area. And that's where the myeloid cells start multiplying and proliferating. And ultimately produce the chronic myeloid leukemia. So such appears very simple on the signs that there is a gene translocation, new gene is formed, new protein is formed. Very simple. But with the previous treatment in those days, this was a typical chronic myeloid leukemia picture. You see all stages of the myeloid cells in the peripheral blood. We knew about the molecular defects, but there has been paradigm shift in last 40 years. What is the shift? Life history has changed. The molecular technology has changed, and the therapeutic innovation have occurred. Look at what was the life history. Life history in those days was chronic phase. Then it will become accelerated phase. Number of the blast cells little more, hemoglobin going down, platelet going down, and ultimately blast crisis. That means it will be full of blast cells, no mature cells, and patient will die. So it's a 3 years average lifespan of patients with a chronic myeloid leukemia. That was the situation in 50s, 60s, 70s, and even in 80s. And that type of the disease, today you will not see. You will only see the chronic phase. You will never see the accelerated phase. You will hardly see any blast crisis. So that's why it has changed. And over a period of time, the change has occurred also in the therapeutic. From the initially simple tablets like hydroxyurea and busulfan, now it has changed to initially with the bone marrow transplantation, interferon therapy, and after 1999, it's a simple tablet. I'll come to it little later on. So at the molecular level also, the change has occurred. We used to initially identify the chromosome. Then we started looking at the translocation by FISH technology. And that has been now changed over to the molecular technology. We have the PCR technology. We are able to really quantitate the BCR-able gene product. So this was a treatment which has changed. And you can also see that innovation has also occurred. I'm going to give you an example of one of my patients. Her name is Mrs. Shaila Bandari. First seen of, her birthday was 24th October 58. And on April 1990, that is about 32, at the age of 32, she went for the routine blood count because one of her relatives was sick and she had to donate the blood. So she went for the routine count and they detected WBC count of 2 lakhs. And all her life was absolutely shattered by that report. Everybody told her, the first doctor told her, you have leukemia. And leukemia in those days was a bad name. She went to the nearby doctor. Doctor told her, you have leukemia. She went to the specialist. They told her leukemia. And they told her that your survival is 3 years. You will have chronic phase, accelerated phase, and acute blast crisis. She had 2 daughters. She literally, both her husband and she, they were crying loudly. So that was a time when they were in Bombay and they came to our hospital in those days. And talking to them, I did realize that they have lack of knowledge and information. And we told them that you have chronic myeloid leukemia. And we said that there are treatment is there. You don't have to worry. But the treatment may not cure you just now, but you will live. She was little bit soothed by that, but nothing great, because she had read up the books where it was written that 3 years is the median survival. So that's the time ultimately we started her on the hydroxyurea, and after some time we also offered her the bone marrow transplantation. May 1990, we had offered her allo stem cell transplantation. She had 4 brothers and 1 sister, but none of them had the matching HLA typing. That was a problem. And then we had told her, and she made almost all the experts from all over the world, whether it's in UK or USA. Everybody told her that, look, you try and search for the HLA matched unrelated donor. And she was on the world tour for that, to get the HLA matched donor, but they could not find. She met Dr. Goldman in May 92, and he ultimately started her on the interferon. That was the second treatment which came up. And again, it was started, but after 2 years, it had to be given up because of severe bacterial infection. However, after some time, again it was restarted. But mind you, all the time, her Philadelphia chromosome was positive. That was a lady with her daughter, and she was so much attached to her daughter. She says, my children have to get married before I die. And therefore, I'll go all around the world and make sure that I can be cured. That's the time the new drug had just appeared, the so-called STI 571 or Gleevec. And it was just, she went to Dr. Goldman. He said, it will take me 1 year to get the trial. She traveled to US. USA, they told her that you have to become US citizen to be eligible for the trial. Her brother was in US. They immediately worked up on her. They got her the US citizenship. And then she was offered to be enrolled into the trial. She was the first case of chronic myeloid leukemia from India to be included and accrued in the trial with Dr. Schiffer at Detroit Medical Center. And then every luck was hers. The June 2001, she went into complete response. The VCR became 0. And after that, you can see how VCR has become 0 for many years. So remember, this is from 1990 to 2000, and then now another 22 years. She has been, till 1919, she was on the Gleevec, living a good life. However, she had the problem. Look at her face. It was all wrinkled. She felt very weak, muscle weakness. She felt diarrhea. She felt tiredness. That was her complaint. Every day she will ring me up, say, I'm getting this trouble, diarrhea. She was so much attached to me that for every minor thing, she will ring me up. She had a water retention, weakness, GI disorder. And that's the time in 2019, we offered her that we can stop the Gleevec, and maybe your all symptoms will disappear. So that's what happened in October 2019. Then look at what has happened after that. We went on doing the quantitative BCR-ABL, and look at it from 2019 till 2022 January, it was more or less normal. And that time, the discussion was that the moment VCR-ABL goes up, you are supposed to reintroduce the Gleevec back. And that is what I offered her, that let us restart, because you are in December 21 and January 22, the VCR-ABL has gone up. She said, I'm living a good life. You have given me 2 years of wonderful life. I have no problem. I'm running around. How can I restart and go back to the same phase? I say, but otherwise the disease may come back. She says, doesn't matter. When it happens, we'll see. I say, fine, we are with you. And see, after that, we have been doing the quantitative BCR-ABL, and it is relentlessly going up. But mind you, even today, our WBC count remains normal. The BCR-ABL is going up. So the question is, which also arises, see, when the disease changes its whole life history, it brings out the new question. When are we supposed to start the treatment again? Shall we do it now? Or shall we wait for till the WBC count becomes high and she develops a typical chronic myeloid leukemia? Nobody has the answer. Everybody has the answer, only one, that if you restart, she will respond. Will she not respond when she becomes typically chronic myeloid leukemia? Nobody has answer for that. So this is what is the problem today. But you can see that BCR-ABL is going up and above. And you look at her, she's very well, she's enjoying her life, she's having no side effects, and that's a whole situation. So what I have told you in short, in a single case of chronic myeloid leukemia, starting from 1990, was a typical chronic myeloid leukemia, Philadelphia positive. And she had 3 years to live. And today we have reached to a stage where we have stopped the drugs. The disease is under control. Although at molecular level, the abnormal gene persists. How long will it take for the gene to produce the chronic myeloid leukemia is unknown. There's hardly any data on that, and when you will get the disease back. And I think that's where the new question arises. But mind you, dear colleagues, students who are going to study more and more about chronic myeloid leukemia, that the disease which we saw, chronic phase, accelerated phase, blast crisis, you will hardly be able to see. What you will see, new question, and you have to find out new answers. Thank you very much.
Thank you so much, sir. That was very informative. If anybody has any questions, please could you leave them in the chat box.
Okay, Dr. Pavitran.
No, thank you, sir.
Okay, thank you very much.
Thank you very much, sir.
Thank you. Thank you.
Sir, there is one question for you. In the chat box, sir, there's a question for you.
Yeah.
One question in the chat box, sir. Yeah.
In the
Chat
Sir, it
box.
says at what level do you restart the TKI therapy after reaching a complete molecular response?
At what level you will stop?
Restart, sir, after a CMR. When will you restart the treatment if you have stopped treatment for chronic myeloid leukemia? That is the question, sir.
See, today the question is that we should have already started the Gleevec with the rising BCR-ABL. That's a teaching. Teaching is start immediately. Get back into the remission. But in the second remission, whether we should ever think of stopping BCR-ABL remains to be known. Because if the patient is chronic myeloid, favorable type of chronic myeloid leukemia at the time of presentation. After some time, for 3 years, if the BCR able remains 0, we can stop the treatment. But if a patient who has a slightly accelerated phase, or the person who is an unfavorable feature of chronic myeloid leukemia at presentation, it's very difficult to recommend stopping the treatment. So I think probably once this patient achieves complete metabolic response, I will never advise her to stop.
There is another question, sir. What are the treatment guidelines for blast phase of CML?
Last crisis.
Yes, sir.
Yeah, I can tell you, blast crisis is the most lethal disease. I mean, we treated large number of them, and we could hardly get any response. But there are two types of the blast. One is lymphoblastic crisis, and another one is a myeloblastic crisis. Lymphoblastic crisis does respond well to a treatment like acute lymphatic leukemia. Same BFM protocol, and so many other protocols can produce complete remission. But even in them, once the Philadelphia chromosome is positive, we recommend that after the treatment, they should undergo allo bone marrow transplantation to achieve the cure.
Thank you so much, sir.
Thank you.
Thank you so much. So I would like to invite Dr. Vijay Kumar, sir, to give the next talk.
Good evening. Dr. Pavitran, can you hear me?
Yes, sir. We can hear you loud and clear.
Yes, sir.
Go ahead.
Thank you. Thank you. I'm able to see Professor Suresh Advani, sir, Dr. Raghurav, and of course, Dr. Pavitran. Others, I don't know who they are. My dear friends, at the outset, I would like to thank Dr. Pavitran and other organizers for inviting me to be a part of this program. Dr. Pavitran instructed me that I should speak something which should inspire people. I do not know where to start. That's why I chose this topic, so that it will give you at least overview. At the same time, what is happening today and tomorrow will be covered. With that in mind, I have chosen this topic. And let me see. No, it's not moving. Yes. Surgical oncology, by definition, it was once upon a time 3 R's: resect, reconstruct, and rehabilitate. And a surgical oncology in the beginning days were expected to perform unique and complicated surgical procedures, and is a part of the multidisciplinary approach. During the past, it was in 20th century, if you look at it, it was more of a mutilating because it was anatomic in nature. There are no scientific rationale. The few factors change the whole scenario. One is the tumor biology, another is imaging, and of course the surgical technique, technology, radiotherapy, and chemotherapy. If you look at the tumor biology as a whole, in the 1800s, it was Halsted, whose name everybody knows, said that the tumor spread occurred orderly and centrifugal, and hence he designed a surgery called en-bloc removal, that's called as radical mastectomy. It actually stayed for a long, long time with some scientific basis. But in 1960s, Fisher came and said, no, tumor does not spread in an orderly manner. There is something called embolization, and bloodstream is important, and en-bloc the surgery is not required because lymph node are not barriers. This changed the whole scenario with respect to cancer surgery as a specialty, as well as the principles changed. We started changing even the technique of doing surgery. The next came the role of pathology. For example, yesterday we used to call only for diagnosis using light microscope. Today, pathology is being used for diagnosis, prognostication, and the molecular markers and genetic markers for example, in Brim's tumor. And the immunohistochemistry, which is very, very important today in lymphomas, we have started using flow cytometry. And to that extent, we have started using the genetic markers to do the so-called tailored therapy for an individual. The role of imaging also moved. During my days, when I started my career in 1980s, we have only one plain X-rays and contrast, nothing more. And so we have to, for everything, when you suspect, we have to open and see surgery and then declare it operable, operate, declare it inoperable, will close. That was the scenario. Today, the imaging has moved to help us to give the information where it is located, how much it is located, whether it is operable or not. 90% of the times you will be able to tell pre-operatively itself. To that extent, we have moved in the imaging with the usage of ultrasound, CT scan, MRI, PET CT, etc. And PET CT is a functional imaging. In other words, surgeon is better informed prior to surgery, and hence we are better equipped to do it and tackle it. This example you see, this side is what you are seeing is the barium swallow. That's all we had in the 80s and 70s. Whereas today, you look at the other side, we have got a PET CT I'm showing, where such a small node which could not be picked up by fingers was able to get picked up by the imaging, which changes the whole staging. This was not the case earlier, and so the failures were more thinking that it has recurred, but in fact we have missed the spread disease. Today, the imaging has gone to that extent we can precisely do the staging and tailor our treatment as per stage. There are changes occurred in even the principles of surgical oncology. As I said, during accident days, we said more the radical, the better. Whereas today, lesser is better. And surgery was considered as main treatment over in solid tumors in the past. Today, it's one of the part of the multimodality treatment. Even the aim of treatment, if you look at it, cancer control are only concern. Today, cancer control is main concern, but not the only concern. We look at the quality of life, function, cosmesis, etc. For example, if you look at the breast, it was radical mastectomy and it has moved on to conservative surgery in the form of breast conservation surgery or oncoplasty, etc. In the rectum, during my days of career in the beginning, we used to do what is called as abdominal perineal resection, where the whole sphincter, etc. has to come. Today, we are looking at sphincter preserving surgeries. Same thing in the head and neck area, where less and less radical procedures are done, more and more organ preservation and function preservation is the norm of the day. This is a classical example where you can see how the modified radical mastectomized patient looks with no breast and flat chest. Whereas the same case today, we are able to do what is called as breast conserving surgery and oncoplasty, and this is per-op, and once it is removed, you can't even make out whether the surgery has been done or not under the brazier at least, because we have conserved the breast and given almost the equal shape and size of the breast. Look at the bone and soft tissue. I remember my first ever surgical demonstration or the presentation was a hemipelvectomy. Whereas today, it will not be appreciated because this person, as I'm showing here, has lost the limb. Today, we do more and more limb saving procedures that is made possible by two ways of doing it. One is the limb removal or limb saving. In the limb saving procedure, we are trying to remove the tumor as you are seeing there and then place a metallic replacement. Here we are using what is called as custom made processes, and that is the radiologically you are seeing after the closure. And you may be wondering, the same thing today we are able to do not only in the lower limb, in the upper limb. I am showing this is the upper limb one where the whole of the humerus has been removed. You can see the whole of the humerus has been removed and it has been replaced with the custom made prosthesis made out of titanium. Titanium is the compatible with the body, and this is the final result, immediate post-op. But see the way it is, the patient is able to move the limb. This is within 48 hours. That is, again, another lady, this girl's father said, you have to show to people to make them believe. This is my good old ward of 1980s, 90s, early 90s of Kidwai Cancer Institute, where I was the professor there. And now I'm making this lady walk without that. She has a limp, of course, pain, because the pain she's limping, because it is immediate post-op. I took the permission of her and the father, who said, yes, you show. So that is the ultimate result. Otherwise, this patient would have gone in for amputation. Today, what has happened to the technology? I said the technique. Yes, yesterday's instruments, there are no special instruments. We have suture ligation, whether we have moved on, the cautery, stapler, laparoscopy, robotic, everything has come. This is a teamwork. This is what our Yanapaya University's team is all about. And we have got the robo. So seeing is believing. Let us see what happens. This is me, my first ever laparoscopic rectal surgery I'm showing. Just for comparison, you see what is happening here. It is same me, and we are trying to do the robotic esophagectomy. See the way the instrumentations are working. See the way they can twist and turn, and see the visibility and the magnification. These are rigid instruments, whereas there we have moved on. Many times I show this younger generation, our past also. See the way I'm struggling, because that is the first ever APR I'm doing 22 years ago with laparoscopy. And the instruments are rigid, and I'm struggling in the third dimension, because the hand-eye coordination is not yet come to the best. That was my first case. And whereas you see here, we have got the lung coming up. It is a post-RTCT case, that is radiotherapy, chemotherapy given case of esophagus. And we are trying to do esophagectomy following that. So comfortably we can do, and this is the prone position, and that is the aorta, this prone. So you are seeing the ulta, we are seeing the upside down. So this is the aorta, this is the lung, and that is the esophagus. So we are able to do all this because of the good technology which has come in. The technology coming in does not mean we have to use only robo. I am trying to showcase that what was yesterday and today and being moving towards. This is actually the esophagus vein. I am going below the esophagus vein to the digest, so that we can dissect and move on with respect to the esophagus. You can see that. See the way the instrumentation is working. Here you see I am trying to ligate, struggling. Here we will be able to easily handle that with the way they are using. Again, these are clips. So you can easily place the clips against the esophagus vein and cut it and come out. So this is just to make the undergrad students, I was told, that MBBS students, to make them understand how we have moved forward and in these aspects. Coming to the once you see the technology and technique, we have to see the training part also. In the short period of time, I can't be showing only the videographs. So you will have to see what happened was more of knowledge-based training was given, basic sciences, then we went to surgical training, etc. Whereas today, because of the lacunae and the uniform training, we are moving towards more of organ-based as well as system-based, which was explained by Dr. Raghunath Rao so well earlier in his spoke. This is the place of my training place. What you are seeing is in Yanapaya University, what we have created, what is called as Advanced Training Center, and for surgical skill enhancement division, wherein actually what you are seeing is the large animal, that is the porcine model, where we are training our postgraduate students how to do laparoscopy surgery in surgical oncology as well as in other areas of field. If you look at the surgeon and radiotherapy, this is the latest version of a radiotherapy machine, wherein long back it was only cobalt-60, and so we were using our deep X-ray therapy. We are using it for palliation and adjunct to surgery. Whereas today it has become a part and parcel of multimodal treatment with improved technology. The side effects are so less. More and more we are using for a local regional control, surgery plus radiotherapy. And this is a brachytherapy machine where we are trying to show not only teletherapy, but locally we can give isotopes. Here we are using iridium implants. And the sophisticated new techniques being used where it's only, two-dimensional. Today we have moved to three-dimensional. and intense modulated radiotherapy. In fact, we can give a stereotactic radiotherapy. So precisely this machine can handle and what we have got. And we are able to treat very large tumors as well as small tumors, and we moved on to the next level. If you look at the chemotherapy part, because why I say I'm talking about chemotherapy, etc., is as rightly pointed out by Dr. Raghunath Rao, it is no more single specialty. Oncology is a multi-specialty. We have to work in tandem, and we are not competing with each other, but we are complementary to each other. So when the person wants it, I have to put the chemo port. This is the chemo port, and here is the place where I have placed the port. Yeah, to give the access to the chemotherapy drugs. This can take easily 2000 pricks. It's a Teflon. This is a Teflon one. It can take 2000 pricks, so that without, struggling to get an IV, number one, and damaging all the peripheral veins, which used to happen in chemotherapy when we take in the limbs. So all this can be easily taken care of. And from simple radiotherapy given only for palliation, we have moved on to make it come upfront. By adding chemotherapy, we call it as chemoradiotherapy, and this is the treatment. Today, we always have given chemoradiotherapy so that the surgery can be reduced in radicality, but it can be combined in such a way organ and functional preservation can happen. As I am talking about it, you may see I am trying to say everything is changed. No, everything need not change. For example, classical neck dissection of radical neck dissection described by Kreil continues to be the same even today for large neck nodes. Radical hysterectomy continues to be the same, and nephrectomy continues to be the same. Because I am trying to say conservation, don't think we are happy doing only conservation. Unfortunately, we do not have control of the patients coming late. And you see this, we have removed everything. We have done the rectum, sigmoid has come out. We have removed the renal pelvis, the bladder, and we have got the ureters there cleared and shown here. And this is called as a pelvic accentration. We try to say, I'm trying to show, because when they come late, obviously the organ preservation is possible. See the way the specimen is. It is the disease, whole disease is here, and thereby we have to remove the whole thing. So there is an element of aggressive surgery when the disease is locally advanced, but when they come early, we always do that and do what is called as function preservation. To make them come early, who will do the job? Somebody may ask. It is we who have to do the job. They won't come on their own in our country. So that is why we have proposed this, and back in our center, Inapaya, we have started with the help of Rotary International. We reach the rural and try to catch them early, get them detected. And this bus, what I am showing, has got the mammography, we have got colposcopy, and all other things which are required to do the screening at their doorstep. The idea is to get it early stage, and thereby, when we try to give it, we will get more and more organ and functional preservation. And on the contrary, what is happening today is we go and teach them, but we alone cannot be doing that. So we take the advantage of our people, our NSS students. We teach them, train them to go outreach. And as a surgical oncology, as a specialty, as pointed, I don't know how many of you heard Dr. Raghunath Rao talking about thoracic oncology, GI oncology, breast, etc. No, more and more narrowing down. But thereby the cancer surgery, then somebody may say it may die. Yeah, it may be die, but it may become more and more organ specific, only to be reborn as organ specific subspecialty of oncology. And surgical oncology in the future may, as I said, it may become more and more minimally invasive. It may become more and more elective, etc. Here is another complete dimension I'm trying to give. Here is the place of actually a nurse who came with ameloblastoma, twice operated, and they are removed, and it has recurred third time. So we don't have something like fibula to be used, which normally we use. Whereas what we have done is we have done a 3D reconstruction. This is a 3D reconstructed and implant we are using by the material called PEEK. This is the specimen we have removed, and this is what we have done a 3D printed in our own setup, and this is what we are showing in situ, and this is the final outcome. This is how she came, and this is the outcome of these are all some of the new things which are happening, which we are able to do because we have something called as technology incubator. Since I am talking to the MBBS students, I am trying to show another direction also. Don't think it is all just surgery, medicine, and etc. There is something more is happening. You have an idea, come to us. You can become a startup. You will make you an entrepreneur. There are enough people to do that. And again, the BIRAC and Government of India, everybody is supporting. And the youngsters have got much more things to do, like 3D bioprinting, 3D metal printer, non-metallic printers. So many things are happening today. As far as oncology is concerned, you have a better poised to choose your career, either in the form of conventional medical oncology, radiation oncology, surgical oncology, oncopathology, etc. We have got, as he said, we have got subspecialties, and you want to go towards the research, yes, and you have got to go something innovation. It is all possible. Today, everything is possible. And that's what I just wanted to show you in a nutshell, an overview of what was done, what is being done, what is possible today. I'm thankful to both these institutions. This is Kidwai Memorial Institute, where I worked for about 31 years. And I'm thankful to that institute, which made me what I am today. And this is Yenapaya Dream to University, where I'm working for 7 years, where I'm making my dream come true. And you all know, yesterday is but a dream and tomorrow is only a vision. But today lived well makes yesterday a dream of happiness and every tomorrow a vision of hope. Let us live well today and treat our patients appropriately and patient-centric, and we'll all will be having a dream of happiness and every tomorrow a vision of hope. Thank you very much. Dr. Pavitra, it's up to you.
Thank you, sir.
Beautiful talk, sir.
Thank you, sir. I wanted to make it as simple as possible, sir. I don't know I made it, because it is MBBS students are there. I didn't want to take them too high. Yeah. If there are any questions, you are welcome.
Thank you so much, sir. The questions will be in the chat box.
Thank you. Are all tumors visible during surgery? Can you explain how they know that you are resected all the cancer? The most important thing in a basic teaching is you should not see the tumor. That answers the first question. Are all tumors visible during surgery? Again, I am insisting the basic thumb rule is you should not see the tumor. That means you come very close and your cut margin will become positive. So what do? We actually feel the tumor and go away. Minimum of 2 centimeters we give minimum in the oral cancer, for example, 1 to 1.5 to 2 centimeters. And in the stomach, it may be 5 centimeters. In the colon, it may be 5 centimeters. But it is also dictated by what we do with the lymph nodes. And so we'll be doing something called a classical hemicolectomy or classical gastrectomy based on the vascularity. So in any case, our idea of doing cancer surgery is not to get cut margin positivity. You must see that at any cost, both macroscopic and microscopically, we should get negative margins as far as cancer is concerned. And that is what we have to aim at. So simple thumb rule is go away. If there is a tumor here, go away. That answers the first question. Is there any real-time imaging that you use during surgery? Answer is no. But the real-time imagings are now coming up as far as oncology is concerned. It is coming up, and now it is not used on the clinical setting. Whereas in the real-time imaging is used routinely for radiotherapy. Every time the CT scan is done precisely, and then only it is delivered. To that extent, radiotherapy has moved. Whereas in surgery, real-time imaging is not done as a part of our clinical, but as I said, lab-wise and experiment-wise, it is going on. Hopefully, we'll get it soon. What are all the cancers you're screening in the screening program? Yes, we can screen everybody, everything, but it is not cost-effective. So if we look at India as a whole, we have got 3 cancers which are superficial, and it is the main load for our country. That is oral cancer, breast cancer, and cervical cancer. And all these 3 cancers will take away the load of at least more than 50% of our tumor burden in our country. And hence, ICMR, WHO, everybody concentrates on screening and early detection of these 3 cancers. This is with respect to routine mass screening, so-called organized screening program. If you are looking at opportunistic screening, that is a person who has got problem is coming, we can screen them for the particular specific symptoms or possible problems. And if there is a target population in the form of, for example, the mother and the father or the sister has got breast cancer, they are worried, they are coming, and we will be screening them. These are all for target population. I'm sure all of you know who is Angelina Jolie, who underwent the prophylactic mastectomy because her mother had same breast, and when they tested, she was BRCA1, BRCA2 positive, and so their score was more, that the chances of her getting cancer was high, and hence she underwent the prophylactic mastectomy and reconstruction. So things are moving in a different way. Mass screening is different, and specific screening for a target population is different. Thank you.
Thank you so much, sir. Now we'd like to invite Dr. Pavitran.
Thank you once again for all the organizers, including Dr. Pavitran, for making me a part of the program. Thank you.
Thank you, sir. Hope the screen is visible.
Yeah, it is visible, Dr.
Okay.
Pavitran. Go
Okay,
ahead.
sir. Okay, sir. Thank you. So coming to the topic of immunotherapy, this is Jimmy Carter, who was the 39th president of the United States, and he was diagnosed with the melanoma stage 4 disease in 2015. He had stereotactic body radiotherapy to the brain, followed by immunotherapy with the drug called pembrolizumab. And 7 years later, he is still free of cancer. And last month, he celebrated his 90th birthday. So the outline of my talk is Introduction to Immunotherapy and Immuno-Oncology, Basics of Immunology, the role of biomarkers, immune checkpoint inhibitors, efficacy data, managing immune-related adverse events, CAR T-cell therapy, and summary. And immunotherapy is now considered as the 5th pillar of cancer therapy. Other than surgery, radiotherapy, traditional chemotherapy, and precision therapy, now immunotherapy is the 5th pillar of cancer treatment. Now, William Coley is known as the father of immunotherapy, and based on his studies in early 90s. And this is the milestones in the discovery and development of immunotherapeutics, starting from William Coley's mixed toxins in 1882 to BCG in 1974, then cytokines like interferons and interleukins, and finally the immune checkpoint inhibitors, the various monoclonal antibodies. Now, the various types of immunotherapy are non-specific immune stimulation with BCG. It is still being used in the superficial bladder cancer, and cytokines, interferons, and interleukins. Interferon is used still in the treatment of chronic myeloid leukemia and some other cancers, and also interleukin-2, which was commonly used in the treatment of renal cell carcinoma, but it is not nowadays used. Then cancer vaccines and immune checkpoint inhibitors and cellular therapy, which are called CAR T cells. The cancer immunity cycle, how our body or the T cells destroy cancer cells. Following the death of the cancer cell, there is release of cancer cell antigens. And this antigen presentation to the T cell results in priming and activation of the T cells in the lymph node. And these T cells get into the bloodstream, and finally it infiltrates the tumors, where they recognize the cancer cells and finally kill the cancer cells. That is what is happening normally in our body. And this T cell response, there are markers or signals that can activate, like so many molecules, CD28, CD27, CD137, etc., which can stimulate T cells, and also inhibitory signals on the other hand, which are mainly CTLA4, that is cytotoxic T lymphocyte antigen, PD1, that is program death 1, and LAG3 lymphocyte activation gene, and few other molecules. But these three are the most important ones and which are also therapeutically useful in T-cell inhibition. Now, what you have to know is about what is called immunoediting or immunosurveillance. When the normal cells turn to transformed cells or cancer cells, they get eliminated in the body by our own natural immune mechanisms, that is by the T cells and cytokines. But after some time, the tumor cells become dormant, that they cannot be destroyed by our T cells. And finally, they escape from our immune system and start growing. And that is how the tumors occur in our body. And the anti-cancer immunity in humans is segregated into three main phenotypes. Usually they are called cold or hot tumors. And there are three phenotypes, that is cold is of two types, either desert or excluded, immune desert or immune excluded, and hot is called inflamed phenotype. This desert means there are no CD8 T cells in the tumor or in the periphery or in the microenvironment. So these tumors will not respond to immunotherapy. Whereas the immune excluded means the CD8 positive T cells are accumulated, but they do not efficiently infiltrate the tumors. So the response to immunotherapy is uncommon. Whereas the T cells, which are strongly infiltrating the tumors, they are very likely to respond to immunotherapy. They are called the hot or the inflamed phenotype. Now, let us see how the cancer cells escape from our immune system. Basically, there are three mechanisms. There is loss of major histocompatibility complex class 1 expression, then increased secretion of cytokines like interleukin-6 or interleukin-10 and TGF-beta, and also upregulation of the expression of immune checkpoint molecules such as PD-1 and PD-L1. Now, immune checkpoint inhibitors are now as the standard of care for many different cancer types. And this is a paradigm shift in cancer treatment. And immunotherapy has resulted in unprecedented improvements in outcomes. Previously, we were targeting the tumor cells either by chemotherapy or by target agent drugs. Our target was the tumor cells. But in the new paradigm of immunotherapy, we are targeting our immune cells. And here the target is a host, not the tumor. And the immune cells, in turn, destroy the cancer cells. The Nobel Prize in 2018 was for the field of immunotherapy for these two discoverers, that is Tazuku Honjo from Japan, who discovered the PD-L1 and PD-L1 blockers, and James Allison from US, who discovered the CTLA-4 and CTLA-4 inhibitors. So basically, there are two ways by which we can inhibit or the natural pathways to accelerate or activate the immune system. That is by blocking the CTLA-4 and also by targeting PD-1, PD-L1 axis. Now, there are many predictive biomarkers to decide on the efficacy of immunotherapy, because immunotherapy is highly effective only in a small subset, that is only about 1/3 of the patients. And the three important markers that have been investigated are PD-L1 expression, tumor mutation burden, and microsatellite instability or microsatellite high or deficient MMR, that is mismatch repair deficiency. PD-L1 expression is generally associated with higher response for most tumor types. However, patients without expression also can respond. So it is not a must for deciding treatment. But if the PD-L1 expression is good, like more than 50%, then you can treat these patients with immunotherapy alone without the use of chemotherapy. And also, the chance of response is good. And tumor mutation burden means it is a number of somatic mutations per megabase. So a high tumor mutation burden is associated with better outcomes with immunotherapy. Then satellite instability again is a good indicates a good response to immunotherapy. That is, these patients are likely to respond in more than 2/3 of the cases. Now, coming to the 4 groups of drugs which are currently approved. One is a PD-1 inhibitors. There are 3 molecules which is FDA approved: nivolumab, pembrolizumab, and cemiplimab. And the toripalimab and sintilimab are approved only in China. Then PD-L1 inhibitors, adasulizumab, durvalumab, and avelumab. Then CTLA-4 inhibitors, the typical example is ipilimumab, and LAG inhibitor, that is lymphocyte activation gene 3 inhibitor, rilaltimab, that is approved in association or along with the nivolumab. So these are the specific inhibitors that are currently used in the immunotherapy. Then efficacy, this is effective against many cancer types. There are more than 24 cancers where that has been tested and proved to be effective. Of these, Hodgkin lymphoma shows highest response. Then other lymphomas, renal carcinoma, and thyroid is the least responsive tumor of these tumors. These are the FDA approvals for various tumor types. And they are also approved. Initially, they were approved in the metastatic setting. Then few cancers were approved for the adjuvant use like melanoma, non-small cell lung cancer, renal cell carcinoma, bladder and gastric cancer. And of late, they are also being approved for use in the neoadjuvant setting, especially for triple negative breast cancer, where they don't express the estrogen receptor, progesterone receptor, and HER2. That is called triple negative breast cancer and non-small cell lung cancer in the neoadjuvant setting. Generally, in a patient, when you treat for cancer, there are 4 types of responses that can happen. Like complete response, that is, the tumor can disappear completely, or partial response, that is more than 50% regression, or stable disease, that tumor may remain same, or progression, that is more than 25% increase in the 4 weeks gap. But the 2 other responses that can happen in patients on immunotherapy are what is called hyperprogression and pseudoprogression. Hyperprogression occurs in about 10 to 15% of the patients during immunotherapy, and also pseudoprogression, that is, the initial lesion may respond, but new lesions may appear. That is called pseudoprogression. So, if the patient is not selected by PD-L1 or MSI, then the response rate is only about 20 to 30%. That is only about 1/3 of the patients generally respond. But if they are positive for PD-L1, that is high positive, like more than 50% positivity, or their microsatellite instability high, then more than 50% of these patients respond to immunotherapy. And survival is generally 12 to 15 months because they also develop resistance. But those who respond to that period, most of these patients are long-term survivors. In the initial melanoma trials, about 40% of them are surviving for more than 5 years and even 10 years. This was a patient with Hodgkin disease, relapsed Hodgkin disease, and she was treated with nivolumab. And you can see the response after 4 cycles, the tumor on the right side has completely disappeared. But with subsequent treatment, after about 1 year of response, she again relapsed and succumbed to her illness. Then another particular problem with immunotherapy is what is called immune-related adverse events. Unlike chemotherapy-related adverse events, these are different because this is just like systemic lupus erythematosus, where there is immune hyperactivation. So basically, we are also activating our own immune system. So because of the hyperactivation, itis, that is, all these systems can be involved with vasculitis, colitis, pneumonitis, all this can happen. So there's a basic problem with these immunotherapy drugs, not hair loss or not even cytopenias. And the common side effects are in the skin and GI tract. That is occurs in more than 10% of the patients. And they usually start about 4 weeks and start improving in about another 3-4 months time. But in some patients, it may persist. And less common are endocrinopathy like hypothyroidism, hepatitis, pneumonitis, and renal toxicity. This skin toxicity is common, and this is a maculopapular rash seen in one of the patients. Then immunotherapy can be used alone as single agent, or it can be combined with another immunotherapy drug, that is nivolumab plus ipilimumab, which is a CTLA4 inhibitor. Nivolumab is a PD-1 inhibitor. And also immunotherapy can be combined with chemotherapy. For example, in lung cancer, usually it is a combination that is used when the PD-L1 expression is low or absent. Then coming to CAR T-cell therapy, that is chimeric antigen receptor T-cell therapy, this is cellular therapy. And this was Emily White, who was treated with, or who was the first patient treated with this type of therapy, what is called CAR T-cell therapy. And she had ALL, and she celebrated her 10th, that is 10-year cancer-free last month. So she was diagnosed with the standard risk 3B ALL in May 2010 when she was 5 years old. But she relapsed in October 2011, and she was planned for bone marrow transplant in 2012, but Emily relapsed again. So she was advised to go home on hospice. But her parents were insistent, and they were exploring all other options. And then they came to know about the CAR-19 trial in the Children's Hospital, Pennsylvania. And she was enrolled in this trial, and she's disease-free even after 10 years. So that means she's cured of her illness. So it's a new cancer treatment that activates a patient's immune system to attack and destroy cancer cells. And this, in fact, is a living drug. That means because it is a T cell which is active and can live for a long time in our body. So based on the somatic mutational prevalence, cancers can be of 2 types. That is those with a high mutation, like most of solid tumors, and with the low mutation, usually the leukemias and other cancers. So for tumors with high mutation, they respond to immune checkpoint blockade. That is our immunotherapy. Whereas tumors with low mutation, somatic mutations, they respond better to CAR T-cell therapy. So the CAR T-cells are prepared by taking the T-cells from the patient by the apheresis, that is just like taking the blood and as using the blood transfusion. The white cells or T-cells are separated, then they are activated, then the virus vector is introduced into that, and then these T-cells are expanded and they are cryopreserved and then finally transfused to the patient. It's just like blood transfusion or stem cell transplant. There are 6 drugs approved for, till now, there are 6 molecules that are approved. These names are all little complicated, but the indications are mainly for ALL and relapsed lymphomas, diffuse large B-cell lymphoma and mantle cell lymphoma. And 2 drugs are for, or 2 CAR T-cell therapies are for refractory and multiple myeloma. Unlike chemotherapy, the side effect profile of CAR T-cell therapy is also different. The 3 important side effects are what is called cytokine release syndrome, then immune effector cell-associated neurotoxin syndrome, that is ICANS, and the macrophage activation syndrome, or HLH, hemophagocytic lymphohistiocytosis. These are the 3 special side effects that occurs with the CAR T cell therapy. Now, there are more than 5,500 clinical trials that are investigating PD-1 inhibitors, and more than 80% of these are combinations. Some of them are with chemotherapy, some of them are with radiotherapy, some of them are with various other drug combinations. So the future of immunotherapy is very bright. So to summarize, immunotherapy as monotherapy or combined with other agents is approved for a number of cancers, generally results in higher response rate and survival than the original standard of care. However, only a subset of patients respond to immunotherapy. We need better biomarkers. Immunotherapy can cause immune-related adverse events, which are generally managed with corticosteroids. Thank you. So there is always hope, as shown this Bansky's drawing.
Thank you so much, sir. Now we'll be taking questions in the chat box.
Can I just answer that the previous question which I forgot to answer? Dr.
Yes, sir, yes, sir. Yes, sir. Yes, sir.
Wonderful lecture. I
Thank
hope
you,
you will permit me to use your slides
Yes, sir.
for teaching. Real
Sure,
good
sir.
teaching.
Sure.
Somebody had asked me, what
No.
happened, why don't the lower mammals or
And
the
invertebrates, yeah, invertebrates.
notochords develop tumors? If you look at the immune system, the defense mechanism starts appearing from the early coelent rats. That means even if you look at Hydra, you know the Hydra, which has small tentacles. So tentacles with small sting cells. So they actually throw something like a hollow needle with a sac filled with poison at the prey. The intention was to paralyze the prey and eat the prey. That was the original intention. And slowly it got transferred into a defensive mechanism. So the earliest cells are the phagocytic system cells. That means the neutrophils and the monocytes were the earliest cells to appear in the immune system. So what we call the non-specific immune system or the phagocytic cell system, which actually processes the insoluble antigen. That means if they are big enough and they are not soluble, so to say, they process the insoluble antigen. If you actually watch the earthworms, the neutrophils leave the body of the earthworm through its pores and are actually wandering around in the surrounding soil. And then they come back into the earthworm with that information. So from that stage onwards, in the early reptiles, yes, you do find B and T cells as well. You find humoral as well as T cells. But it is only in the birds as well as in the mammals that you find a very strong self and non-self system. So the self and non-self system is highly operational in with the advent of the T cell systems. So the T cell system is the peak of immune development. And if you actually watch the how the evolution occurs, the highest level of immunity is what contributes to the highest level of animal forms, including man. So the anthropoid apes, that is the gorilla, gibbon, chimpanzee, and orangutan, also have the same immune system like we have, and the rhesus monkey has the same immune system. So it is easy to do it. But you cannot use any transplanted tumor in an animal simply because it is a xenograft and it will automatically get killed. So we use either thymic nude mice or we create animals without the thymus, so they cannot react to you using cell-mediated immunity. I hope I have answered your question. So we don't find a very strong immune system in the lower forms of marine life and the lower forms of animal life, but the self and non-self is what actually creates the so-called immunity against cancer also.
One question was regarding cancer vaccines. vaccine, there are two types of vaccines. One is the preventive vaccines, that is, which is usually used for the cervical cancer, that is HPV vaccine. And there are three vaccines, that is Cervarix, Gardasil, and the Indian one, which is not yet available. It was just recently approved. And other one is the therapeutic vaccines, which is used in prostate cancer, which is called Sipuleucel T. Other than that, all are in the early stages of development.
Can we use HPV vaccine for pre-leukemic conditions, that is CIN 1 and 2, and perhaps in CIN 3? There are a few trials which have used them with varying degrees of success. So that is using the preventive vaccine in pre-invasive forms of cancer. Can we use it in already formed cervical cancer? Possibly we are not there yet. There are several vaccines. In fact, there are a little over 16 vaccine trials in cervical cancer. Whether it can potentiate the value of radiation therapy and chemotherapy, yes, it does seem to help in the potentiation. More importantly, it looks like that if you use the vaccine against cervical cancer, the other pre-invasive cancer types, that is the vulval cancer, vaginal cancer, anal cancer, and the oropharyngeal cancer, including genital warts, seem to be very effectively prevented. So we know that it acts at more than one side. The other vaccine which we routinely use for children, that is the universal vaccination, is hepatitis B vaccine, which can also prevent hepatitis B induced chronic liver disease, cirrhosis, and hepatocellular carcinoma.
Sir, there's one more question in the chat box. What kind of immunotherapy is given in people with coexisting immunosuppressive diseases like HIV?
No, in immunosuppressed patients, actually, it is a contraindication. Like transplanted patients and patients on autoimmune diseases who are on immunosuppressives.
Okay, sir.
Yeah, we can't use it.
One more question is there on the chat box. How does T-cell transfer therapy work against cancer?
That is actually the CAR T-cell therapy is the typical example, where genetically engineered T-cells are used in the treatment. There is patients' T-cells are taken, then they are genetically engineered to modify to work against the cancer cells. That is the CAR T-cells.
Thank you so much, sir. Now we'll be having the vote of thanks. Good evening, everyone. I am honored and lucky to have the opportunity to give the vote of thanks today. Firstly, I would like to thank all the speakers for their valuable time. We have learned a great deal and are very much indebted to you for your knowledge. Thank you. Next, I would like to thank all the organizing teams, volunteers, teachers, and staff members. And finally, I want to thank all the participants for making this event a grand success. Thank you.
Thank you.
Thank you, Dr. Pavitran.
Thank you, sir.
Yeah, wonderful listening to you. Bye-bye. Good evening, Dr. Vijay Kumar, sir. Vanakkam, sir. Bye, sir. Bye.